Good evening, everyone, and welcome to another series of International Dermatology Education Foundation educational series. My name is Lain Kircik. I am the president of International Dermatology Education Foundation. I am also a clinical professor of dermatology at Icahn School of Medicine at Mount Sinai in New York City, as well as at Indiana University Medical Center in Indy. I am also the medical director of Physician Skincare, my clinical practice in Louisville, Kentucky, as well as my clinical research center, Skin Sciences in Louisville, Kentucky. Tonight, we are very lucky to have Dr. Ted Lain from Austin. He is the Chief Medical Officer of Sanova Dermatology, and he's the Executive Director and Principal Investigator at Austin Institute for Clinical Research in Austin, Texas. And we're gonna discuss a single prescription for triple combination topical acne treatment. But before we go there, I just want to tell you a little bit about International Dermatology Education Foundation, and I do want to thank our supporter, Ortho Dermatologists, to make this evening's program possible. And before we begin, if you're having any issues hearing the webinar, you can listen to presentation using your telephone. Just select phone call in the audio pane, and the dial-in information will be displayed. At the end of this webinar, a survey will pop up in your browser and will be emailed to you within 1 to 2 days. We would greatly appreciate if you could fill out this very short survey. If you're having technical issues tonight, please submit your questions in the questions pane on the right-hand side of your screen. And also within 1 to 2 days of the webinar, a certificate of attendance will be emailed to you. If you have any questions, please submit your questions using the questions pane on the right-hand side on your screen at the end of the session. However, remember the questions should be unlabeled. Now, International Dermatology Education Foundation is a nonprofit organization whose principal mission is to raise awareness and improve dermatology care all over the world through education, especially in underserved areas. And since through the pandemic, we've been broadcasting several educational sessions, as you can see some of those examples here in this slide. So before we go any further, I'd like to invite Dr. Ted Lain, who's a good friend of mine, and he is gonna discuss a single prescription for triple combination topical acne treatment. Welcome, Ted, take it over.
Dr. Kircik, thank you so much. It is such a pleasure to be here and to talk about one of my favorite medications, which is CabTrio. Let me see, there we go. So CabTrio, right? And we can see up on the top right, clindamycin, adapalene, and benzoyl peroxide. That's the Cab in CabTrio. The Clinda is at 1.2%, the adapalene 0.15%, and the benzoyl peroxide at 3.1%. This is a single prescription, so it's the first time we've had 3 ingredients in one topical acne treatment that is now FDA approved for use once a day for acne vulgaris in patients 12 years of age and older. My internet's, I think, a little bit slow, so I have to wait for the, let me see. It is not advancing on my side, guys.
You want me to move it for you, Ted?
Do you mind, Leon? Can you move it to the next slide?
Sure. Well, it's not moving for me either. Let's see. You try it for a second. Let's see.
Okay, let me try it again. No.
No luck?
Still no luck.
Is Nico there? IT guy?
Yes, I'm here.
Nico, can we move it for us?
I think Ashley has, hold on, give me a second.
Sorry, everybody. It's a really great drug, so don't go anywhere.
Well, while we're waiting, let's talk about this. Why is the adapalene is on the lower concentration, Ted?
You know, that's the concentration they found that kind of weighs the efficacy and tolerability, right? So at 0.15, we get excellent efficacy, but we don't sacrifice any tolerability for it. you know, it's, as we'll talk about, it's a very special formulation, Dr. Kircik. So it is meant to disperse the actives across the skin surface in a very even manner. So perhaps because of the micronization and the dispersion, we honestly maybe don't even need that high of a concentration in order to achieve a really good effect, like we'll show you in this deck if we're able to get to it.
Hopefully we will.
I know. I probably have it memorized. I probably get to walk through it with everybody.
I'm sure you can.
Yeah. But you know, this is why it's really important, you know, just off the cuff here, I've had a lot of people say, well, I'll just get this compounded. You know, first of all, it's illegal to get this compounded. This is an FDA approved drug. So A, it's illegal. B, you will never know what the concentrations are in reality if they make it as a batch by batch without testing. And then you also don't know the stability of it, right? So I would be very hesitant in compounding this. Certainly a compounding pharmacy should not even try to compound this, or they in my view, could put themselves at risk. So it's something where we really need to focus on using the named drug and prescribing it at one of our specialty pharmacies. Now, the next question that I often get is, okay, well, I'll just do, you know, adapalene and benzoyl peroxide in the morning, and then I'll do clindamycin at night. But you know, if you do that, then you're using two different things. And as I'll show you in the deck, when you start going from one medication to two medications, the compliance plummets. So it's really important to consider the opportunity to use one drug with three different ingredients and how that will translate into excellent compliance for our patients.
And you know, I always say vehicles matter, right? So the vehicle is so unique here.
I know. Yes, the vehicle is very unique. That formulation and technology, you know, which underlies a lot of the more recent orthodermatologic topical products, whether we're talking about Araslo, for example, or others, they've got this vehicle that is just so special. So if you're a big fan, as most of us are, of Araslo, you're going to love CabTrio, because it incorporates the same technology in the same vehicle. So we're able to, again, you know, make these.
Leon, can you see the screen now?
I do.
Okay, you guys have mouse control.
Okay, let me check.
Try. Actually, Ted, why don't you try?
Okay, here we go. I'm trying. Okay. Ah, I do.
Perfect.
Yay.
Thanks, Nico.
Thanks, Nico.
My pleasure, guys.
When I was in high school in Spanish class, we had to choose a name, a Spanish name, and my Spanish name in high school, it was Nico. So you're very near to my heart. Okay. More than anybody wanted to know. All right, so these are my following affiliations. Chief Medical Officer, we've gone through that. Okay. Uh-oh, Nico.
Not moving again.
Oh no, Nico. Here we go.
Here we go.
I think it's just going too fast. No, there we go. Okay, guys, we're good. Okay, so this is the first line dual combination therapy that includes the benzoyl peroxide with the antibiotic and a retinoid. We haven't had this previously. And as I mentioned, it's so important that we have all three in one, because when you start increasing from one to more than two to two or greater, you can see what happens to the compliance. Primary non-adherence, yes, it's highest in teenagers, 39%, which is tremendously high. But it doesn't get much better when people become adults, does it? Over 34 years is still 34%. And you know, those of us who take a couple of medications a day, especially you have to take one in the morning, one at night, can attest to this, that it's kind of hard to remember to take something twice a day or one in the morning, one at night. So I totally understand this. And that's why something like this, where again, one prescription with three ingredients really is just huge for compliance for our patients, which tells us that maybe we'll actually achieve the success that we have in clinical trials, where we know that the compliance is better because we have diaries, we're paying the patients, we're seeing them frequently. Okay, let's go into this design and formulation that Dr. Kircik and I were talking about. First of all, the ISI. It's contraindicated if there's a hypersensitivity to any of the components. It also talks there about lincomycin. So clindamycin is a synthetic derivative of lincomycin. You're not going to see lincomycin anymore, but perhaps, you know, there's somebody maybe from another country or who knows that talks about an allergy to lincomycin. That would transfer to clindamycin as well. And then, of course, because we're using clindamycin, any history of enteritis, ulcerative colitis, or antibiotic-associated colitis, that would be a contraindication. Hypersensitivity reactions have occurred, including angioedema, anaphylaxis, and urticaria. Of course, you want to discontinue and treat. Colitis can be associated with clindamycin, so if diarrhea occurs, discontinue. Photosensitivity may be caused by CabTrio, although we don't often consider adapalene as a photosensitizing retinoid, but it's in the retinoid class, so this is in the ISI. Avoid or minimize exposure to sunlight and sun lamps, and of course wear sunscreen and protective clothing. Skin irritation and ACD or allergic contact dermatitis can occur with all of those symptoms that are listed there. Be careful in cold or hot weather. Of course, if some kind of irritation occurs, add more moisturizer, decrease frequency, and then avoid using the broken eczematous skin, and of course avoid use of waxing unless patients have stopped the CabTrio 7 to 10 days prior. And CabTrio has not been used in conjunction with any other topical medication. The most common adverse reactions in more than 1% of people in the trial were application site reactions, local skin reactions, stinging, burning, erythema, pain, that kind of thing, dryness, irritation, exfoliation, and dermatitis. And of course, you should not use it when patients are receiving neuromuscular blocking agents as well. So Clinda is a lincosamide antibiotic. Adapalene, as we know, is a third-generation synthetic retinoid, helps to modulate cellular differentiation. So it kind of slows down proliferation, slows down differentiation, decreases keratinization. All of that we think is the reason why retinoids help with acne, although the exact mechanism is unknown. Benzoyl peroxide is an antimicrobial. It carpet bombs everything, right? So it helps to kill the bacteria associated with acne, the C. acnes, but it also helps as a keratolytic, although again, the precise mechanism is unknown when we are applying it to acne. Then, of course, we have to think about the duo of Clinda and benzoyl peroxide together with the idea that benzoyl peroxide would kill any antibiotic resistance that may occur because of the use of Clinda, which may be beneficial as well, but the mechanism of action and clinical significance are unknown. All right, this is the magnificent formulation and vehicle that Dr. Kircik and I were talking about. When CabTrio is applied to the skin, a honeycomb mesh is formed. That is the polymeric mesh that's formed. And within that polymeric mesh is water, and dissolved in that water is clindamycin. So it's uniformly spread across the skin. Now on the polymeric mesh are scattered these micronized crystals of benzoyl peroxide and particles of adapalene. And that way we are able to form a very uniform application of all three of the topicals. Now when that mesh hits the skin, because of the skin temperature, it's almost immediately dissolved. And so all of the three actives hit the skin at the same time. This isn't like a slow release formula. Other ingredients include purified water, as I've talked about, the carbohomopolymer, that polymeric mesh technology is made out of that, a touch of propylene glycol used as a humectant to bring water into the skin, but not a high concentration, and then an alkalizing agent in potassium hydroxide. Guess what we don't have in here? We don't have preservatives. We don't have surfactants. We don't have alcohol. We don't have anything occlusive. So really, we have limited this formulation to a very small number of ingredients, such that we don't have many other chemicals that could cause irritation to the skin, especially to the skin barrier, which we already know is affected by acne. So that's really nice that we have something with such a low number of ingredients. When we talk about the clinical development program, of course, it went through the whole development. I'm going to focus on phase 2 and phase 3. Now, the FDA said, look, it's great to have 3 ingredients in one, but you've got to show us that the 3 ingredients are better than 2 ingredients. So that forced OrthoDerm to have a trial where CabTrio was compared against all the different dyads that can occur by the 3 ingredients. So adapalene plus benzo, adapalene plus Clinda, Clinda plus benzo, you get the idea. And so that caused them to have essentially a 5-arm study. Now, the patients were all 9 years of age and older. They had to have moderate or severe acne. The EGSS is Orthodermatologic's IGA. It is the subjective assessment of acne severity. Think about it very much like an IGA. That's what we're more used to. Now, the patients had to have at least 30 inflammatory and 35 non-inflammatory and less than or equal to 2 nodules. Now, if you follow acne and read acne studies, you know that that's a high number of baseline acne lesions. Usually it's less than that in terms of the number of inflammatory and non-inflammatory that are required in the protocol. So that's a high number. These patients, you know, you never want to compare trials, but especially when you think about some of the particulars of this trial where you look at that number of lesions, it's higher. These patients had a large number of papules and comedones. Now, these are the 5 different groups. We've got IDP 126, which is CabTrio, the dyads, which we talked about, and then the vehicle gel. Each one of these groups had about 150 patients in it. You could see the discontinuation rate was between 9 to 15%, so not a very high discontinuation rate. You can see the reason for all those discontinuations listed there. Of note, the reason of being an adverse event is low. I always look at that. Discontinuation due to an AE is very low. Lack of clinical efficacy, essentially 0 to 1. And then what else is there? The adverse event, that's about all that or worsening acne, also 0 or 1, only 1 in vehicle. So, okay, we're getting the idea discontinuations happen in every trial, right? We can't handcuff patients to trials, but what's the reason for that discontinuation as listed gives you an idea that it's really not related to the drug, most likely. Let's take a look at the patient demographics. So these patients are about 20 years old, about 60-40 female to male. Different races were incorporated in this trial. 20 to 22% were considered Latino. About 16 to 20% of patients were Black. So certainly we have skin of color represented in this trial, which is wonderful. When you look at the inflammatory and non-inflammatory lesion count, if you add those up, we're looking at about 90 to 100 lesions per person. So again, a significant acne burden in these patients, although the EGSS skewed heavily towards moderate. So about 80 to 85% of patients were moderate, the rest severe as per the protocol. The primary endpoints included treatment success, which is that EGSS of 0 or 1 with a 2-grade improvement. So if they were moderate, they could get to 1 and get a 2-grade improvement. If they were severe, in order to get to 1, they had to get a 3-grade improvement, right? So that the more severe the patients, the harder it is to achieve treatment success. Absolute change in inflammatory and non-inflammatory lesions was also a co-primary endpoint, and assessments were conducted at those time points listed there, baseline, 2, 4, 8, and 12 weeks, and then safety, of course, was captured. Let's jump into the efficacy. This is the first primary endpoint that we talked about, treatment success, 2-grade improvement in EGSS with a 0 or 1. And the CabTrio is that dark blue bar. All the dyads are the other colors, and then vehicle is the gray. And what you can immediately see is like, yeah, okay, we're percolating along, and the dyads and CabTrio are doing just about the same at week 4 and week 8, but boom, between week 8 and week 12, in terms of a subjective assessment of acne severity, you see a huge jump, such that the CabTrio totally outperforms the dyad. So there is synergy when these 3 ingredients are placed together. And so this is what told the FDA, okay, now we can move into phase 3 because we have some sort of magic going on where with the 3 ingredients put together, we see an improvement, an IGA or EGSS improvement that heretofore we have not seen with a single agent. So again, if you follow acne, if you read trials like Dr. Kircik and I do, this kind of number has not been seen before with a single agent at week 12, okay, in terms of IGA or EGSS response. So we're getting the idea from phase 2 that, wow, we're dealing with a real winner here. In terms of safety, this is any treatment emergent adverse event. Now, what's interesting is that when you look at those groups that had the higher adverse events, it's those with the adapalene. So it seems like the adapalene is driving some of these AEs, right? In terms of the serious AEs, very few. Discontinuation rate due to AEs, very low. Again, something that I look at when I think about the tolerability of a drug is the discontinuation due to AEs, and it was very low. So severity of AEs, also the vast majority were mild to moderate. For those that were severe, you could see in terms of the CabTrio, burning and stinging caused the severe assessment, and that was in 4 and 2% of patients. So yes, it's a combination of benzoyl peroxide and adapalene and Clinda. You would imagine that the benzoyl peroxide and the adapalene may cause some local tolerability effects, perhaps, but again, in the trial and as in real life, we're going to surround this with some excellent skincare to really mitigate any kind of tolerability issue that your patients may experience. And then you can see how the duads, or the dyads, I should say, fared as well, and everything fared pretty darn well. It's just that CabTrio with the 3 ingredients fared surprisingly well. So this is results from a phase 2 trial. This is a 14-year-old Asian male. Okay, so this is moderate at baseline. Wow, incredible. I mean, this is a fast responder. This is a great responder. Within 4 weeks, had tremendous reduction in the number of lesions, continued improvement there. And this patient is clear, you know? So again, I just want to show you, bear with me. This is where we started. And then 12 weeks later, 1 cream, this is where we ended, okay? So 1 cream once a day, just want to reiterate. Now we're looking at the phase 2 trial, inflammatory lesion count reduction. This is a more kind of slope of a line that we're used to seeing with acne products, where it's more linear, right? And the problem is, well, it's not really a problem. What is so impressive is the number. Again, one cream led to an over 75% reduction in inflammatory lesions by week 12. Again, guys, we haven't seen that. We just haven't seen it. And if you're thinking to yourself, well, I mean, my oral antibiotics get me there, that is absolutely false. Your oral antibiotics as monotherapy don't do very much at all, and I'll show you that near the end of this talk, okay? So usually you need an oral antibiotic with the topical to achieve any kind of efficacy that's appreciable, and here we're showing it by itself. Non-inflammatory lesions, 71%. So what you see with inflammatory, you see with non-inflammatory as well, which kind of makes sense given the 3 ingredients that are included. And by the way, look at the dyads. The dyads all kind of come together at week 12. They kind of do what they're able to do. All of them are about the same, which is interesting, I thought, at week 12. But when you add that 3rd ingredient, you get a jump in efficacy in terms of reduction of inflammatory and non-inflammatory. Now I'm showing you a black female, 13-year-old black female, mixed acne here, right? Inflammatory and non-inflammatory. And this was, I'm sorry, I should tell you, this was a baseline EGSS of 3. Again, wonderful response by week 4, continued beautiful improvement by week 8, and then at week 12, we're here. If I showed you these photos, guys, if I showed you these photos and didn't tell you what was used, I bet some of you would say, well, that could be Accutane. And I'm not saying that CabTrio is Accutane. I'm not saying it's topical Accutane. I'm just saying when you see that kind of an efficacy, it is not something that we are used to seeing with a topical by itself, okay? And so you have to start elevating your expectations with this drug. It absolutely changes the way we should think about topical therapeutics for acne. Let's go into the phase 3 trial. 9 years of age and older, moderate or severe EGSS, 30 and 35 inflammatory, non-inflammatory, less than or equal to 2 nodules. All the sites were in North America. Again, 2 studies, pivotal, randomized, identical studies. Guys, look at the number. N equals 183, N equals 180. That is such a low number. You know, most of the acne trials that Dr. Kircik and I have run in the last 10 years, we're looking at in the high hundreds to thousands of patients. Why? Because they needed that kind of number to power their trial appropriately so that they could achieve statistical significance at the end point, okay? Here we're showing you an extraordinarily low number, and this was because OrthoDerm was informed from their phase 2 trial that this drug works so darn well that they don't need a huge number of patients to show statistical significance at week 12. And indeed, they didn't need it. I'll show you otherwise the drug wouldn't have been approved, right? So we've got these wonderful, results from phase 2 that allowed us to perform a phase 3 trial with not this huge number of patients. And you can see completed study, 90, 89, 90% for those who dropped out, very low dropout rate related to adverse events. So again, speaking to the tolerability, in my view, of this drug. Co-primary endpoints are going to sound very similar compared to the phase 2. Key secondary endpoints, now we're looking at percent changes and percentage of patients achieving a 2-gradient reduction from baseline at week 12 without necessarily achieving as a grade 0 or 1. Compliance, safety, tolerability, all of these are very standard. In terms of, as I mentioned, there was integrated skincare that was allowed. Subjects were authorized to use only investigator-approved non-medicated cleansers, moisture sunscreens. Non-comedogenic makeup was allowed, but they couldn't wear makeup for their study visits. Wash their faces with cleanser and warm water. Pat their faces dry. Apply a pea-sized amount in 6 areas to the face. That's not 6 pea-sized amounts, guys. That is 1 pea-sized amount touch to 6 different areas of the face, and then rub in, and then moisturizer can be applied in the morning. A moisturizing sunscreen can be applied as well. Again, can't reiterate enough the importance of the integrated skincare in order for your patients to be able to tolerate this, like we saw the tolerability in the clinical trials. You have to mimic what we did in the clinical trials if you expect to get the same results in clinical practice. So the patient demographics here, similar to phase 2, the age was about 20. The females are about 60-40 female male. Again, about 20% of patients were, well, depending on the trial, right? 10 to 20% of patients were Black, about 25% of patients were of the ethnicity of Hispanic or Latino. So again, the idea that skin of color was represented in these trials. Again, we're seeing a high burden of acne, 80 to 90 to 100 papules, pustules, open and closed comedones were on these people's faces. And then the EGSS, again, the vast majority were moderate, the rest were severe. Compliance is listed there, 90 to 100% compliance, which is exactly what we want with one treatment once a day. Wow, look at this data for EGSS success. It kind of mimics what we saw in phase 2. Again, consistency in data gives us confidence in data, and that's what we're seeing here. 50, 51%, almost exactly the same treatment success we saw in phase 2. So confidence, 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 that's what I'm thinking about here. And we see the same idea, percolating along, getting better at week 4, better in week 8, but there's a huge jump between week 8 and week 12. So that perception of acne severity kind of may be a little bit more delayed than the improvement in acne lesion count reduction, which is I'm going to show you here or after this. So this is the safety outcomes in the pivotal trials. Application site AEs, pain in about 13%. Pain incorporates stinging and burning, okay? Erythema in 4.5%, dryness, irritation, exfoliation, dermatitis, all those pretty darn low. So it's the highest is a bit of stinging and burning. Almost all of that was early on, can be fixed with more moisturizer, decreasing frequency of application as well. This is the cutaneous tolerability assessment at the 12-week clinical trial in study 1 and study 2. So this is pooled data. And again, mild, moderate, and severe, right? How severe was the erythema? We know that its incidence was what I think I said 13 or 14%, but the vast majority of those were mild to moderate. Only 0.5% were considered severe. Only 0.9% of burning and stinging was 0.5%. So again, yes, these LSRs occur. There is a retinoid in there. We kind of expect to see some LSRs with 3.1% of benzoyl peroxide, not surprising, but the vast, vast majority are mild to moderate and easily taken care of with integrated skincare, in my opinion. Here we go. I feel like I missed, nope, I didn't miss it. Okay, so look at the results from the phase 3. So this is a 14-year-old Asian female. Okay, this is a severe patient. I don't think anybody would argue this is a severe patient. We have a lot of papules and pustules scattered across the skin surface. This is like the picture of a severe patient. What happens at 4 weeks? Okay, we're getting quite a bit better. You know, we see a reduction, at least I would say about 50% reduction in the number of papules and pustules. Continued improvement over time, such that by week 12, this patient was considered mild, which I would agree with. But look, you know, 2 grade improvement, right? Not treatment success. So we're not showing you a treatment success, but I think that we'd all be quite happy when our patient starts here, okay? And then with the erythema and inflammation associated with that, and then gets to here where the erythema and inflammation has largely resolved. We see papules and pustules that are relatively not inflamed. And I think continued use of the drug, it gives me the idea, at least, that continued use of the drug, we may see continued improvement. I wish we had that data to show you. But of course, all these acne trials have week 12 as their primary efficacy endpoint. Look at this. This is inflammatory lesion count reduction. And remember where we were in phase 2, 70%. We're at 75 and 80% here. It's just unbelievable. We just haven't seen these numbers with any other drug. So again, the idea that we are elevating the bar, elevating expectations, this is why topical therapy for acne is so important and why we need to support companies that innovate in the topical space, because this obviates, in my mind, the need for an oral antibiotic. It may delay other treatments or replace other treatments as well that can be more expensive and cause more side effects. So when you see a 70 to 80% lesion count reduction by week 12 in inflammatory lesions, again, we just haven't seen that in other clinical trials. I'm not talking about head-to-head, just other clinical trials that we have done. Here we're seeing almost the exact same thing with non-inflammatory. So what we see in inflammatory, we see in non-inflammatory. Makes total sense. This drug was meant to do that, right? You've got the clindamycin, which is kind of the antibiotic, it's anti-inflammatory, it's kind of the mother ingredient in the formulation. You've got the benzoyl peroxide, which doesn't play well with others, okay? It's kind of the chihuahua ingredient, right? Always uppity. It's hard to mix with other ingredients. And then you've got the adapalene, which is kind of the surfer dude of ingredients, right? It's the retin A that we all want, but it's really cool because it plays well with others. It doesn't get messed up by the benzoyl peroxide. It plays well with clindamycin. It is chill. So you've got this kind of mother ingredient, the chill ingredient, and the chihuahua ingredient all mixed together. And because of that, with no preservatives, how do we do that? Well, the clindamycin kind of acts as a preservative there, doesn't it? And yes, it's broken down very slowly by the benzoyl peroxide, but it means that we didn't need a preservative in there that could have caused more local skin reactions as well. And I think that's why we're seeing such great tolerability, which I'll show you. This is a 14-year-old white female, grade 4 severe at baseline, improvement already at week 4. So this patient is thinking, okay, I want to keep using this drug. I'm seeing improvement by week 8, my goodness. And then by week 12, again, not a treatment success, but that looks pretty good. That looks pretty darn good on her skin, and you know, not a lot of erythema, not a lot of inflammation either, despite the fact that we have adapalene and benzoyl peroxide in this formulation. Here we're showing you an 18-year-old Hispanic male, grade 3, moderate. Okay, let's see how we do here. Okay, we're seeing quite a big reduction. We see a lot of PIE on that lower cheek. Now we're seeing great decrease in the number of papules and pustules there. And here we only have a few. Again, not a treatment success, right? Got to a 2, but clinically, I think we'd be very happy with this. And the patient will probably come in with a big smile on his face saying, thank you for prescribing me such an efficacious topical. Grade 3, moderate on this 18-year-old white male, already improving by week 4. That large kind of cystic lesion near the nose has resolved after 4 weeks. Skin is looking great there. And then almost clear. So this is a treatment success by week 12, okay? And note that there's not a huge amount of inflammation or irritation associated with this topical. How about, does the efficacy improvement translate to improved quality of life? This is how we capture that with Dermatology Life Quality Index and acne specific quality of life questionnaire as well. So this is the acne QOL. I'm sorry, I misspoke. This is not the DLQI. This is the acne QOL. This is related to acne, and this is the least squared mean change from baseline. So the higher the number, the better the improvement. The blue bar is the CabTrio, the gray is the vehicle. Self-perception, emotional role that acne plays, the social role, the active symptoms, all of these have improved. So important to show you this because, you know, patients with acne have a hit to their self-confidence and their self-esteem that translates into adulthood as well. So if we're able to fix this early on, if we're able to decrease how much the acne affects their self-perception, their emotional and social lives, and how many symptoms they experience, it is a very big deal for the rest of this person's life. Look, there was another trial that was done. Dermatologists did not sponsor this trial. This was an independent study, meta-analysis that was done in the Annals of Family Medicine, where, look, the authors looked at a meta-analysis of acne clinical trials with 221 trials that they looked at. 37 pharmacologic treatments for acne vulgaris were examined, and they only looked at the percentage reduction in total lesion count. And they compared the trials. They compared the investigational products in the trials. So you remember how I said oral antibiotics by themselves are not the bee's knees? Well, you could see at the very bottom there, oral antibiotics, the 11.6 is the lesion count reduction, right? So very low. We don't use oral antibiotics by themselves. If you do, stop. And then you've got topical antibiotics by themselves, not very good. And then as we keep going up, okay, we start getting the combination, right? Oral antibiotics plus retinoid plus BPO, topical antibiotics and azelaic acid, topical retinoid and BPO. When you start getting combinations, you get more efficacy. But look where CabTrio fits in. We just highlighted that for you in the pink. It fits in right below oral isotretinoin, doesn't it, in terms of lesion count reduction. I told you that the lesion counts, we just haven't seen those with other trials, especially with other trials with one treatment, right? And so it's so unique to see that. And here, this is just supporting these claims that I'm making in this meta-analysis of 221 clinical trials. So in summary, right, we have to speak a little bit, because it's got benzoyl peroxide, it's in the back of everyone's mind that Valashir petition to the FDA about benzene as a breakdown product of benzoyl peroxide, but seems to be related to heat exposure. Well, look, Orthoderm is doing everything it can to prevent heat exposure. From the manufacturing, wholesaler distribution to the pharmacy, everything is in cold chain. It hits the pharmacy in cold chain, okay? Which means it's absolutely not related to any, not exposed to any heat. Now, what happens from when the patient picks it up from the pharmacy to when it gets home? No control over whatsoever, okay? But there are, storage instructions on the package of CabTrio that says, do not freeze, keep it room temperature, keep away from heat, store it upright, dispensed with a 10-week expiration date as well. So Orthoderm is doing everything the company possibly can to prevent any kind of breakdown to benzene related to heat exposure with this drug. And totally in summary here, remember this is the first and only FDA approved fixed dose 3-in-1 topical acne prescription. We see EGSS clearance rates of over 50%. We see lesion count reductions of over 70% for inflammatory and non-inflammatory. Again, it's designed with a very limited number of ingredients that kind of allows us to avoid the use of preservatives, alcohol, and surfactants. The treatment emergent adverse events were, for the vast majority, were mild to moderate. They tended to occur early on in the clinical trial as well. The idea of retinization is there. And remember, one script, one pump, once a day gets you to the place where historically we would rely on multiple prescriptions, which leads to an issue with compliance that I spoke about earlier. All right, how do you get this for patients? It's all great to have a great medicine, but you got to have access, right? So Orthoderm is doing the very best they can. In this current environment, they are doing a yeoman's job, okay? So $0 copay for the first RX and any eligible refill, $75 copay when commercial insurance does not cover CabTrio. And they have orthorxaccess.com. Of course, speak to your rep as well. We have, I prescribe the heck out of this drug and I haven't had many issues at all in terms of access. And I'd be completely honest if I did, but I just haven't. So it's been very good, at least where I practice in Austin, Texas. So additional orthodermatologic products include Arazlo, which is that tazarotene lotion 0.045%, FDA approved in 2019. And you can think about this for patients with acne vulgaris age 9 and older who just need a topical retinoid, okay? Or you've got this new drug CabTrio for those 12 and older who need a topical combination, triple combination therapy in a single script. You've got two different options from one company. Both, again, utilize that wonderful formulation and vehicle that Dr. Kircik and I were talking about. Because I mentioned Arazlo, I've got to go through the ISI. It's indicated for acne in 9 years of age and older. It's for topical use only, not for oral, ophthalmologic, or intravaginal. Can't use in pregnancy. It's got tazarotene. On label, you need to check a pregnancy test 2 weeks prior to starting it, and it should be done around a menstrual period. It can cause irritation, just like the other retinoids, interrupt or decrease frequency. Photosensitivity may occur, so be careful there. And then it shouldn't be taken in addition to drugs that are known to be photosensitizers. Weather extreme may cause a problem. The most common AEs were application site pain, dryness, exfoliation, erythema, what we expect from a retinoid overall. All right, guys, thank you so much for your attention. I apologize for the technical difficulties we experienced early on, but that happens. And I'm happy to take any questions.
Thank you, Ted. Thank you for that very eye-opening and very nice lecture about this new product. And I was involved with the phase 2 study, so I remember, as you mentioned, even at the phase 2, when we had so many different arms, the number of the ends in each arm was so small. And I was truly concerned that it may not get there, it may not show statistical significance. However, it certainly did, and it tells you about the power of this product.
Yeah, thank you, Leon.
So we have a couple of questions. One is really a good question, very practical. How long does 50-gram pump last?
So a one pump should last you about 2 months is what I would say, okay? Especially if you're just using it on the face. Now, if you're starting to use this on the chest and back, and I don't have data on the chest and back, but assuming that you want to use one product everywhere, then it's going to last not as long, but it should last you about 2 months.
Now, you did mention that Arazlo, I believe, was indicated all the way down to 9 years of age. However, CabTrio is 12. Can you elaborate a little bit on that? I just want to make sure we've got the right numbers.
Yeah, so although patients 9 to 12, 9 years of age and older were included in the clinical trials, I just don't think we had enough, the number of patients in that age group for the FDA to to give ortho that kind of clearance for 9 and above. So I don't think that there is any safety issues at all, Leon. I think it's just purely the number of 9 to 12-year-olds in the trials.
And again, you know, I cannot not talk about the vehicle. Sorry, shoot me, but tell us what's not in the vehicle, right? That's really important.
Yeah, and I tried to stress on that, but it's a great thing to point out again. There are no preservatives, there are no surfactants, there's no alcohol in there either. So those ingredients that you would kind of attribute to some local skin irritation related to a vehicle aren't in there. And so it's very unique in terms of not only the technology of that polymeric mesh, but also the number of ingredients is so low. And again, it points to kind of the magic behind those 3 ingredients and how they allow for that.
And if I heard you correct, you did say that clindamycin is sort of playing as preservative, right?
Yeah, that's from what I understand, speaking to the formulators of this, that the Clinda is actually, serving a couple of different purposes in that formulation.
So that's really cool that they were able to put all those 3 products together. I always call it's like dreams come true, right?
Yeah.
People always trying to do this, a retinoid, an antibiotic, topical, and benzoyl peroxide together, and finally it came to fruition. Yeah. But the very last slide that you showed, it was almost too good to be true. And the meta-analysis that this product is second best compared to isotretinoin, I shouldn't say compared, but second best to the isotretinoin in that meta-analysis, correct?
That is exactly right. It was the very top product, including trials that incorporated oral antibiotics and topicals combined. This came out on top. The only thing better in the meta-analysis was the isotretinoin.
Yeah, that is really amazing. So let's see here. Patients to take here's another question. Patients to take multiple drugs and can have good compliance if they see the burden of the disease using 1 compounded or 3 individual component drug. So basically it's about the compliance.
Yeah, certainly efficacy drives compliance, but I think when you're talking about a teenager in particular, of course, if you can achieve even better efficacy, as we've shown you in that meta-analysis with 1 product, I can't imagine the reason to choose 2 products.
I agree 100%. So on that note, I know, guys, most of our audience probably have some more important things to watch tonight. So I will stop here and wish everyone a good night. And I also want to thank again our supporter, Dermatologist. And now that we're done this program, I do want to invite you July 9 with Dr. Jennifer Song on mild to moderate atopic dermatitis in skin of color patients. Thank you, everyone. Thank you, Dr. Lain, and have a good evening.
Thank you, Leon. Thank you, everybody. Enjoy the night.
Thanks. Bye.
Bye.
Are we done?